Our next speaker, we're going to carry on with the topic of genomics and trying to understand what gene sequencing is and the advantages of gene sequencing. And with Dr. Alex Wyatt, who is a PhD in our lab here at the Vancouver Prostate Center, one of our up-and-coming super scientists, brilliant young man. Is that enough?
Thank you very much.
Okay.
I'll give you the bribe later.
Yeah, all right. He's going to prime us on what gene sequencing really is and how it can impact on how we manage patients, particularly with more advanced disease. Alex.
Good morning. So I'm afraid I have actually tweaked a few of the slides this morning while I was sat at the back, so it's not going to be, there'll be a little bit that's off-piste compared to your booklets. As way of background, I actually did my PhD, although they call it a DPhil at Oxford, I think to be a little less French. I did that in human genetics, so I have a somewhat similar background to Dr. Schrader, who spoke just before the break. And as she mentioned, of course, cancer is a disease of the genome, so when I was looking for postdoctoral positions, I sort of moved towards cancer genetics and cancer genomics. And now that I have my own research lab at the Vancouver Prostate Center, we focus particularly on treatment resistance cancer genomics and trying to understand why a given tumor has become resistant and potentially what else we could do. So there's a little bit of overlap here, but I think some of these concepts are important to emphasize. Cancer is a disease of the genome, so what we mean by that is that changes to the DNA within your cells is what results in cancer. And it's because of mutations to important genes. Incidentally, I think a few scientists even now could be forgiven for not really knowing what the Genome Project is. But I love pictures like this. These are fascinating. This is, as Intan showed, it's a picture of the chromosomes from a normal cell, and you have two, one from your mum, one from your dad. And in this case, the researcher has actually painted them in different colors. Now, just to give you a sense of what an advanced cancer cell would look like, here's a snapshot. So you can see straight away how different that is. And that's because over the lifetime of a cancer, it starts to accrue all sorts of genetic changes, mutations, losses or gains of chromosomes. You can see, for example, chromosome 13 here is completely missing. Now, those of you in the audience may know, or maybe not, that BRCA2, BRCA2, is actually on chromosome 13, so the very gene that Intan talked about earlier has had 2 hits in this particular cell. So why is this important? Well, these mutations and these changes are what enable the hallmarks of cancer. So we think about things, the cells have their accelerator pedal stuck on or brakes that don't work. And it's actually these DNA changes that are enabling that. And so, you know, we can think about the way in which cancer survives. It evades the immune system. It encourages blood vessels to come in, to grow into itself, to supply it with nutrients. And this is all enabled by changes to the DNA sequence. We think of normal cells as having these checks and balances, these sort of systems that have evolved over millions of years to prevent cancer arising, essentially. So if a cell begins to try to divide, we have all these genes that kick in and say, wait a sec, you're not a dividing cell, stop. And we call these genes tumor suppressor genes. Essentially, they suppress tumors. And so one of the ways in which cancer can develop is mutations to tumor suppressor genes. So as that cell that then accrued a mutation, perhaps through UV light or ionizing radiation or other forms, as that then goes to divide, that key check and balance is now gone. And the cell divides and becomes a mass. Incidentally, onco, I think, is it comes from the Greek word, which literally means mass. And so when we think about oncogenes, which is maybe the opposite of tumor suppressor genes, it's genes which can gain function and increase, say, proliferation or increase angiogenesis, blood vessels and nutrients into the tumor. So you have these combinations of changes to tumor suppressors and changes to create oncogenes. But this is quite a complex picture, and the reason it's complex is because the way in which different cancers get gain these changes is different from patient to patient. So we, in terms of the community, understand quite a lot now about how localized primary prostate cancer develops. There are some tumor suppressors which are recurrently changed. But if one takes any individual cancer, it's normally a unique signature, a unique combination of things. So that's kind of what this picture encapsulates. It's looking at 300 odd tumors and showing that, yes, there are things in common, but there are as many things that are different between tumors as there are in common. And that therein is why cancer is such a challenging disease to study, because each patient develops cancer down its own unique avenues. In prostate cancer, though, there is a sort of homogenizing effect, and that is controlled by the androgen receptor and the testosterone hormone signaling axis. And the reason for that is, even in a normal prostate cell, your androgen receptor, your testosterone signaling axis is functional. And those checks and balances that I talked about are preventing the androgen receptor from causing any downstream proliferation. So what happens in prostate cancer cells, those checks and balances are gone, and now testosterone can enter the cell, bind to this protein that we call the androgen receptor. And the androgen receptor can then go ahead and result in cell proliferation, for example. So in this picture, this kind of schematic here of testosterone entering the cell, binding to the androgen receptor, and the androgen receptor sort of controlling the cell, resulting in proliferation, resulting in sort of, the soldiers going forward, normally would be prevented by those tumor suppressor genes, but is no longer anymore. So despite these different tumor suppressor genes that each person's cancer changes, you can see why hormone therapy is pretty much uniformly successful to start with. It's because regardless of what changes down here, you're still dependent on this testosterone signaling axis. So which is why if you deplete testosterone, you kind of, cut this proliferation supply off at the top. Unfortunately, we know that if one gives enough time, then treatment resistance and progression to this is inevitable. And what is fascinating in some ways and scary in others is the way in which this treatment resistance arises. The primary way is that the androgen receptor in these cancer cells changes. So one of the ways in which it changes is you end up with multiple copies of the androgen receptor in each cell. Rather than just the one copy you should have on the X chromosome, you now have tens. And so you can think almost like a dosing situation. So now you don't even need any testosterone. It can kind of function on its own because there's so many copies of it. Another way is it can mutate so that it doesn't actually need to bind to testosterone anymore. It can bind to other steroids, to adrenal steroids, potentially progesterones or corticosteroids. So it sort of, learns how to survive without testosterone, without the standard hormones, and adapt to that condition. Now, we know there are also non-androgen receptor related mechanisms of resistance using other oncogenes or tumor suppressors that can compensate for the loss of the androgen receptor pathway. So once again, there's this sort of heterogeneity, these different mechanisms by which treatment resistance arises. Importantly, though, because the androgen receptor is still central to a lot of those processes, one can hit it again and again. So this has been the remarkable success in the last decade of retargeting the androgen receptor with drugs like abiraterone and enzalutamide, and other ones that have entered the clinic in the past 5 years or so. They're giving remarkable overall survival benefits, and this is happening because they're targeting the androgen receptor in a more potent way and knocking it back again. I think Thomas is going to talk about a range of these therapies, so I'm not going to go into too much detail here. But suffice to say, though, once again, resistance is inevitable. So you can kind of think about these cycles of knocking the cancer back and it adapting and learning to account for those therapeutic differences. Now, we're starting to understand what's going on with all these resistance mechanisms, why a given cancer would be resistant, why it would respond for longer than others. But yet we still don't have strong molecular biomarkers. So tests, essentially, that can say for a new patient coming in, what is the likelihood that you would respond to this therapy or this therapy, and how long will it take before you're resistant? This is very important information to help make these treatment decisions. And the reason for this is because historically, to develop this kind of biomarker, you need tissue. And prostate cancer has been uniquely difficult to get tissue from because the metastases tend to go to the bone. And the bone is a very difficult place to get a tissue biopsy from. Luckily, this is all starting to change. And it's because really of a revolution in the way that we can study cancer. So we at the Prostate Center and other multi-institutional centers around the world are really now moving to the liquid biopsy to study prostate cancer at this late stage. And the reason why this works is because cancers are incredibly inefficient in the way that they grow. And they're dying all the time, their cells are turning over, they've got scant regard for previous generations of their own cells. So they're shedding DNA into your own bloodstream all the time. So what that means is that from a small blood sample, you can actually get the DNA from the cancer. And so you can then study the very changes that are occurring within the cancer through a liquid biopsy. So we're going to try to move, I think, from this concept, this sort of premature concept of precision medicine, where a genetic test result maybe just suggests exercise more, eat less. And in fact, we and others have been publishing several papers over recent years showing that, in fact, we can take the very things that we detect in this circulating DNA from the tumor that's present in the blood, and we can see changes that are relevant to treatment resistance. It won't surprise you, given what I've been saying, that a lot of that might center around the androgen receptor. So one can see the mutations that are arising in the androgen receptor and predict how that will affect therapeutic response. There was all this has been augmented by a remarkable study last year that was a multi-institutional $10 million study that did actually obtain tissue from 150 men with therapy-resistant prostate cancer. And this picture is difficult to see, but the point is that each one of these bubbles represents different groups of genes that were changed in each patient. So different sort of oncogenic pathways within a cell, different ways in which a cancer cell is able to grow and act independently of testosterone. And this is important because in the laboratory, we're starting to develop ways to target these sort of discrete pathways. And so if we can begin to detect which cancer cells are using which particular oncogenic pathways, once again, we can think about perhaps how that would influence therapy response, and maybe we can think about complementary strategies to try to co-target these pathways. So what we now do, and when I say we, I mean the community of oncologists and urologists that collaborate with my groups, and the patients that provide their blood samples. And I must say, if any of you in the audience have contributed to these studies, thank you so much. You're enabling some really transformative research, and we really appreciate it, and we're going to try to repay you in spades. So we're now collecting in our clinics blood routinely from most men with treatment-resistant prostate cancer. And so what we're doing is we're extracting that tumor DNA from the blood, and we're looking at those changes that I've discussed. The androgen receptor changes, the changes in those particular signaling pathways within a cell that might give us an idea of what route a cancer cell is using to grow. And this is important because Kim Chi, my close collaborator and friend, who's going to talk in a couple of talks' time, will describe how we can use this information to actually get better at treating this late-stage cancer strategy. So, as an example, For example, we can see things like this particular gene is called beta-catenin. The gene itself doesn't really matter, but in early stage prostate cancer, in primary prostate cancer, it's very rarely changed in patients. Even early on in treatment-resistant prostate cancer, it's also rarely changed. But when we look at prostate cancer that has received many lines of therapy, this actually becomes very common. So what that tells us is that this particular gene, and there are many examples like it, is actually linked to aggressive prostate cancer and potentially linked to prostate cancer that's refractory to current therapy. Similarly, the genes that Intan was talking about earlier, those key hereditary prostate cancer genes, the sentinel example in prostate cancer being BRCA2, one is able to see those changes in the liquid biopsies that we take. And one can see the germline change, the hereditary change that one gets, plus the second hit that occurs in the cancer cells. So this is important because if we can detect this, then we can tailor the way in which a patient is managed based on these aggressive changes. So why does this all matter? What's the summary? What's the take-home point? So cancer arises because of changes to DNA, but also it's influenced by contribution from the germline, as we heard earlier. So these changes influence aggression and response to therapy. So by studying these changes and seeing what happens in each patient, we can understand which ones lead to aggressive prostate cancer, which ones lead to indolent prostate cancer. What's difficult is that each patient has a different set of alterations. And while there are commonalities, we really need to get to this sort of personalized genomics. And we now have the tools to do that, the liquid biopsy. Especially in later stage patients, we can regularly sample patients through a few mils of blood, and we can see these personalized genomics. So what this is enabling now is a really exciting era where the liquid biopsy can inform on tumor genomics and potentially influence patient management. And from my point of view as a lowly PhD, it really is exciting to see this sort of merging, this rushing together of the basic science side together with the oncologists and the urologists that are seeing patients. And so I really hope that as the months and years move on, this will entirely meet up in the middle. My acknowledgements, I think, for this talk should center on all patients and their families that have contributed to the work we're doing at the moment. But also Kim Chi and other urologists at the Prostate Center who are working with us. Thank you very much.
Okay. Thanks so much, Alex. So a lot of interesting work going on, and I'm sure that you've stimulated a lot of questions, which we'll get to in our next panel. Our next speaker is the founder of this conference, Dr. Thomas Beer from the Knight Cancer Institute in Portland, Oregon. And Tom's going to bring us up to speed on some of the advances in how we treat the more advanced castrate-resistant prostate cancer. Tom, you ready?
Yep, we're ready. Can everybody hear me? Great. I will assume that's a yes.
Yes,
all right.
We can hear you, but if you can speak louder, that will be bonus. Thanks.
Okay, I'll get closer to the microphone. So thank you for this chance to speak to everybody today. We're going to shift gears a little bit from the genomic and scientifically oriented talks into treatment for advanced prostate cancer. I'm grateful to all the speakers that went over their time, because that gives me a little bit of freedom to maybe go over my time without feeling so bad. I have a fair amount of material to share with you, and that's good because, when I got started in this field, once a man had received hormonal therapy for prostate cancer and their disease became what back then we used to call hormone resistant, we had precious little to offer. And now we have 6 life-extending therapies that we can do. And so there's a lot to talk about. And following this talk, Kim Chi is going to take us through what's on the horizon. I think the world's changing very quickly. I'm going to start with an image. This is an image we obviously never want to see. A man whose prostate cancer has unequivocally metastasized to the skeleton shown on a conventional scintigraphic bone scan. And so I'm going to talk a little bit about the changing landscape of metastatic castration or hormone-resistant prostate cancer. Talk most extensively about the new hormonal agents, but also review the status of chemotherapy, immunotherapy, and bone-directed therapy, and talk a little bit about molecularly directed therapies, which I suspect Kim is going to expand upon further. So a changing landscape. I think it's important as we look at the data, and I'm going to show you an awful lot of data, to recognize what era the data are from and not quite compare a study from 10 years ago to a study today, because things have changed a lot, in part because treatments are much better, and in part because our practice is changing and we're treating patients earlier and more aggressively. And so we can't really compare patients from 20 years ago to patients from today, even if they're technically defined in similar ways. And so here's an example of what I'm talking about. The top graph, and these are survival curves. You're going to see a lot of those, so let me pause for a moment and introduce what these graphs look like. What you see on the vertical axis is the proportion of patients that are still alive or perhaps free from disease progression, whatever the endpoint that we're talking about. In this case, it's overall survival. And on the horizontal axis is time. So as you can see over time, the curves drop from 100% of patients surviving to some lower percentage. It's a graphical way of showing what the survival expectation is in a particular study. So on the top, you can see mitoxantrone. That's the first chemotherapeutic approved for prostate cancer. It did not improve survival, but it did improve quality of life. And the median survival at that time was a year. That's what the world looked like when I got started in this field. Today, the median survival of patients starting chemotherapy for hormone-resistant prostate cancer is closer to 3 years. So that's the cumulative result of all the new therapies, as well as more vigilant and aggressive care. And I think this big picture view is important, both to understand the data and also to recognize that although each therapy may be adding only a few months in a particular study, when you take the aggregate of everything we're doing, men are living 3 times longer than they used to be when they get the diagnosis of hormone-resistant prostate cancer. We're also, of course, reminded that we have a long ways to go, because what we would like to see is a survival curve that doesn't go down at all and people continue to live. These are the agents that we have available now that have been shown to improve overall survival, and a summary table of the types of studies that were carried out, what they were compared to, the hazard ratio for overall survival, which is a common way of expressing the size of the effect. The smaller the number, the better in this case. And you can see that we have Sapolsel T, an immunotherapeutic, 2 chemotherapeutics, docetaxel and cabazitaxel, 2 hormonal agents, abiraterone and enzalutamide, and 1 radiopharmaceutical, radium-223. And I'm going to show you the main efficacy results, survival results for each of these agents. So first, starting with the androgen receptor, the new hormonal agents. There are really 2 strategies that have evolved here. They've evolved from an understanding that hormonal signaling remains critically important in driving prostate cancer growth. And we use the term signaling. That's kind of a weird term, but what happens inside a cancer cell is that a hormone comes in and sends a signal for growth. So that's what I'm talking about when I say hormonal signaling. And there's 2 ways to try to get after this. One way is to further reduce the hormone levels both in the blood and in the cancer cells. And the other is to block the androgen receptor, which is the main way that hormones signal through their receptors. And so abiraterone and enzalutamide are examples of those two strategies. If you're more used to brand names, that's Zytiga and Xtandi, but I tend to use the generic names to try to reduce the commercial nature of the talk. So abiraterone and enzalutamide have been studied in 4 large global randomized studies and shown an overall survival advantage in all 4. So this was really a clear advance, unequivocal results, 4 out of 4 positive studies. They were studied in the pre-chemotherapy setting, where they're largely used today, and also in the post-chemotherapy setting, so in patients who'd been through chemotherapy. And the results were positive regardless of exposure to chemotherapy, and that's important to recognize. I'm going to start with and really focus on the pre-chemotherapy studies because time prohibits me from showing you everything. It's published data. You can certainly look for it if you're interested. But also the pre-chemotherapy setting is how we use these agents today for the most part. So how does abiraterone work? Well, it works remarkably effectively to further lower hormone levels. So when you take a healthy man, their circulating testosterone might range anywhere from 200 or 300 to 500 or 600. Donald Trump's is at 440 something, just as a baseline. And if you, I'm taking no political stance. It's the only presidential candidate who released his testosterone levels, so that's. And in any event, if we were to put Donald Trump on Lupron, his testosterone would drop to somewhere between 10 and 30. That's what we typically see. But if we were to add abiraterone, it would drop another 10 to 15-fold down to a level of something like, say, 1. So it is a much more potent suppressor of hormone production than conventional hormonal therapies, be it orchiectomy or drugs like Leuprolide. And so if you lower hormone levels more, you have a positive effect on outcomes in patients with advanced prostate cancer. And this is a graphic, one of those survival curves, focusing here on progression-free survival. So the average patient who was treated with the control group, which included a low dose of steroid prednisone, saw their cancer progress in 8 months. The average patient who received abiraterone as well as prednisone saw their cancer progress in 16 months, so a doubling of the progression-free survival time. These are, obviously, we want these to be years and not months, but this is a pretty substantial difference. It's a meaningful difference for many patients. The survival difference was not as great, but that's in part because these patients get other therapies after their disease progress, and some of them even can get access to abiraterone itself in the control group. Nevertheless, it was a clinically and statistically significant improvement in overall survival. Now, shifting to enzalutamide, I have a few more details on this, not because it's a better drug, it's just that this is the drug we've been most involved with, so it's a little closer and near and dear to our heart. This cartoon shows you how it works. It does not lower testosterone levels at all. What it does is it blocks the androgen receptor and keeps it from enabling testosterone to stimulate the growth of cancer cells through hormonal signaling. In the initial phase 1/2 trial, which the University of Washington group participated in, and we and them, as well as Memorial Sloan Kettering and subsequently some additional institutions, were the first to treat patients with this drug. And these are PSA reductions in individual patients. So each one of these blue bars or lines is a single patient. You can actually see the PSA reductions that the patients that participated in this trial experienced, and you can see that whether patients got chemotherapy or not, a large majority of them had some PSA declines, and more than half had PSA declines of 50% or greater. We enrolled 140 patients on this study within about a year, which was really exciting time, seeing new responses and doing a study very quickly. This led to the PREVAIL trial, which was the largest international trial focused on a cancer-directed therapy for hormone-resistant prostate cancer, enrolling 1,700 patients to enzalutamide or placebo, and looking at a range of endpoints from overall survival to being free from cancer progression, free from the need for chemotherapy, and et cetera, et cetera. I'm going to show you just a few of the results of this study. This is progression-free survival, and the average on the placebo group was about 4 months. Now remember, abiraterone was compared to prednisone, not just placebo, so you can't really compare across those studies. The average for enzalutamide ended up, it wasn't actually seen in this initial report because the study wasn't followed long enough, ended up being about 18 months with a subsequent analysis. Survival looked like this early on and looked a little bit more robust with an additional analysis. But again, many of these patients received enzalutamide or abiraterone post-progression, so it's harder to show as large a survival difference as you see for the progression-free survival difference. The need for chemotherapy was delayed by almost 1.5 years in an average patient, and that's a meaningful benefit for patients. I think most of us would agree. And we also saw an improvement in quality of life. This is a kind of an upside-down way of looking at quality of life. This is time to a worsening in quality of life, and we saw that nearly double on average from about 6 months to almost 1 year. So men treated with enzalutamide saw not only their overall survival improve, but their cancer was controlled for longer, and that translated to better quality of life and less need for chemotherapy. So both abiraterone and enzalutamide have now been approved really worldwide for the treatment of prostate cancer that's progressed on primary hormonal therapy. And that's been a real advance because these agents are quite effective. They're also oral pills. You can take them at home, and they don't have the side effects that are associated with, for example, chemotherapy. So chemotherapy still has an important role to play, even with these hormonal advances. And very quickly, I'm just going to show you the data that we have for chemotherapy. It's a little less striking than the data for these hormonal agents. Docetaxel was the first chemotherapeutic to be approved based on a survival advantage, but the curves for docetaxel versus mitoxantrone are not very far apart, and the improvement on average was about 2.5 months of survival, so not a very large improvement, but in individual patients that difference can be much larger. So this does remain an important tool in the management of the disease once the hormonal agents are no longer useful. And cabazitaxel, brand name is Jeftana for those of you that are more used to brand names, has a similar level of benefit as a second-line agent, so we can now use 2 different chemotherapeutics, one after the other, as needed to treat a particular patient's cancer. Cabazitaxel was recently studied in comparison to docetaxel in the frontline setting. It performed about the same, so it did not change the frontline standard of care. But we did learn that a slightly lower dose of cabazitaxel is better tolerated. And for some patients, particularly patients who have pre-existing nerve damage from something else, cabazitaxel may be a better frontline option than docetaxel because of its toxicity profile. I'm just going to move very quickly here in the interest of time. It's important to know that these new hormonal agents, abiraterone and enzalutamide, have not affected the efficacy of chemotherapy. So even though chemotherapy was studied before the most modern hormonal agents became available, small studies have shown that the level of activity with chemotherapy is about the same after abiraterone and enzalutamide as it was before these drugs were invented. So we've not lost the utility of these drugs due to stronger hormonal agents. So in summary, chemotherapy is still useful. Docetaxel remains active both in patients who have progressed on conventional hormonal therapy and on these newer hormonal therapies, as is cabazitaxel. And, not everyone responds to these newfangled hormonal agents, and so we think for some patients chemotherapy remains a good choice early, but we've not yet figured out how to identify those patients up front, and I'm going to talk a little bit about that at the end of this talk, unless Larry cuts me off. Immunotherapy I'm going to speak about very briefly. Provenge or Sapulcel T is the only approved immunotherapeutic in prostate cancer. This is a cartoon that shows that what happens biologically when you generate Provenge vaccines. What you typically do is you collect some white blood cells from a patient using an apheresis procedure, which is very similar to what you use to collect platelets for the Red Cross. You then expose these cells in the factory to the antigen called PAP, and about 48 hours later you get them back on an airplane and reinfuse them into a patient in the hope of stimulating an immune response against prostate cancer. Provenge was approved on the basis of a survival advantage in a 500-patient clinical trial that was carried out about a decade ago now. So this is what Provenge has to offer. Unfortunately, with Provenge, we don't see tumor responses or PSA reductions, and so it's not quite as a complete an agent in terms of what it offers a patient. And also, we don't have really new data that have shown us any new information about how it performs in the context of the newer agents. So it's out there, it's an option. It's not as well researched and not as contemporary as some of the other drugs that we have available. If we're going to use Provenge, there are some retrospective data that suggest that the benefits may be greater when it's used earlier in patients with metastatic disease. And I'm not referring to earlier as in right after, say, PSA recurrence after surgery or radiation. Julie addressed that a little bit, and I'm happy to address that more in the Q&A. But in its indicated setting, patients with lower PSAs seem to do better. This is a retrospective analysis, and it really shouldn't be viewed as definitive evidence, but it is subjective, and I think merits further study and certainly some consideration in how we think about the timing of Provenge in the care of patients. Finally, the newest agent that we have available is radium-223. It's a particle emitting radiopharmaceutical that homes in on the bones and delivers relatively short-range radiation in the bones. It was studied in a large randomized study that focused on bone-predominant patients who'd received chemotherapy previously and or who were unfit for chemotherapy, so too sick to undergo chemotherapy. In that context, radium improved survival and it delayed complications from prostate cancer in the bone, so delayed things like bone fractures, bone pain, etc. This is a useful treatment in patients whose disease is predominantly in the bones. It is not helpful if the disease has spread to the lungs or the liver or large lymph nodes. Small lymph nodes we do accept. It doesn't seem to produce much in the way of PSA reductions. We tend to use this agent in our center after chemotherapy because we do worry a little bit about the possibility that radiation in the bone marrow could reduce the ability of the bone marrow to produce white cells and to withstand the chemotherapy. So we tend to sequence it after chemotherapy. So in summary, the landscape has changed quite a bit. In 2005, we had very little to offer. One chemotherapeutic. We now have 6 life-extending agents and more on the way. I think you're going to hear from Kim about that. And because I've gone over time, I'm going to skip over some of the molecular slides and just yield the podium to the next speaker. Leave you with a photograph of our research team. These are the folks that do all the work. Many of them are volunteering today to make this conference possible, and I appreciate him a great deal. Now, my staff is in the next room. They'll point out to me that this picture's out of date, and we have a newer picture, and I'll get that next year. I'll try to be a year behind on these. Thank you very much.
Jackie. Okay, thank you very much, Tom. The last speaker in this session before our Q&A, I'm very pleased to introduce Dr. Kim Chi. Kim has been working with us at our Vancouver Prostate Center for many years. He's a medical oncologist, a professor at the University of British Columbia, recently appointed medical director of the Vancouver Cancer Center across the street, and a wonderful speaker. Looking forward to your talk on where are we heading in the future.
Great, thank you, Larry, and it's certainly a pleasure to be here this morning, heading into this afternoon. And my talk is going to kind of build on what Alex was talking about at the first talk in terms of genomics and what we're doing there, and builds on Tom's talk for going from the standard therapy and looking at, okay, what's next? And fortunately, there is a lot going on. That's not mine. Unfortunately, as Tom mentioned, there's a lot going on. So what I'm going to try to do is talk more about concepts and use a few examples for each of those concepts. And I'm going to talk about 3 concepts or 3 research directions so you get an idea about where we're going with things. And so I'm going to start off with this slide first, and this kind of gives you an idea about what happens with prostate cancer. And as we've mentioned, prostate cancer initially is very sensitive to castration therapy or hormone therapy. And so initially, prostate cancer is castration sensitive. It grows on androgens, and then we do the hormone therapy, deplete the testosterone, deplete the androgens, and virtually everybody responds for some time. But what makes cancer dangerous and prostate cancer dangerous is that it develops into this, what we now call castration resistance or hormone resistant state, and that's where all the bad things start to happen. And so Tom talked about all the therapies that we have in this later stage when the cancer becomes castration resistant, so chemotherapy, abiraterone, enzalutamide, and so on, and radium-223. And so the big question, my first sort of research direction that I'm going to talk about is what happens, whether we can bring these treatments that are effective in that later stage setting, in the castration-resistant setting, and can we bring them earlier in the disease so that we can have perhaps greater effects? And a good example of that is with docetaxel. So Tom showed the slide of docetaxel in patients with castration-resistant disease, and those curves weren't that separated, and we were talking a few months of survival gain. But there's been several studies, and this is just one of them, that have recently come out in the last year or two, where we know that by bringing chemotherapy earlier in the disease, we actually see a bigger benefit. And this is all the patients on the study, and here's the survival curve, and now you can see this big separation. I'm not sure if you can see the numbers. I know you can't see the numbers in the back, but it shows us that there's a 40% improvement in overall survival. That's big in terms of cancer terms. And then especially in patients that had a high tumor burden. So here the average survival for patients that just got the hormone therapy alone was under 3 years, but for the people that got the hormone therapy plus chemotherapy, it was closer to 5 years. So this is a big benefit. And now most of the chemotherapy I give now is not for people in that late stage castration resistant setting, but is actually in this earlier setting when the cancer is still hormone sensitive. So back to this slide. So we know that docetaxel, by bringing it earlier, seems to have a greater benefit for these men. So the big question is, well, what about our newer therapies? Docetaxel, that study that showed a survival benefit in this late stage setting, came out over 10 years ago in 2004. And so it's taken us a while to now bring it back here. 10 years later, now we're back here. What about these newer therapies? Are we doing anything about that? And certainly there is, and there's a number of trials that are going on. Here's just a few of them. Here's 5 exactly, and these are looking at, for example, bringing abiraterone earlier in the disease. And these studies have actually already completed accrual, and we should see results in either next year, perhaps. So we should see whether indeed bringing abiraterone earlier in the disease is actually going to help make better improvements, just like what we saw with chemotherapy. And we're seeing this also with enzalutamide, and there's another drug, apalutamide, where again bringing it earlier. And it's even going into localized disease. So people that don't have metastases, people that are at high risk with a localized prostate cancer. So in addition to radiation and regular hormone therapy, can we bring enzalutamide into that setting and help increase cure rates? So that's one concept that we do in oncology. So we find things that work in late stage disease, and then we bring them, try to look at them earlier in the disease setting to see if they can have even greater benefits, longer survival, and perhaps if we bring it into localized disease, increasing the rate of cure. So that's one concept. I'm going to move on to the next research concept, and that's going back to the androgen receptor. So as you've heard, prostate cancer, the androgen receptor and androgen receptor signaling is really important. The prostate cancer is addicted to that androgen receptor. It really wants that signaling to go forward. And so Tom talked about abiraterone, and what that does is it blocks production of the testosterone. And then he also talked about enzalutamide, which directly blocks the androgen receptor, prevents the testosterone from binding to the androgen receptor. Now, most patients, when we use this in that castration-resistant prostate cancer setting, respond to these therapies. But invariably, there are some people that don't respond. It's about 10%. And then some people progress very quickly within 3 to 6 months of getting this drug. And then others, secondary resistance will develop at some point in time. So although they work very well initially, eventually the cancers do end up progressing. And there's a lot of research going into looking at what happens. And it still may be factored on the androgen receptor. So although we're blocking it, the cancer finds a way around abiraterone and enzalutamide. So here again, abiraterone blocking the enzymes and androgen production, enzalutamide directly blocking that androgen receptor. So what are the ways that the cancer may be using to get around this? Well, it may be upregulating the enzymes, bypassing the abiraterone. It may be amplifying the androgen receptor. But a couple of interesting things that are coming out is, one is that the androgen receptor gets truncated. So you get different forms of the androgen receptor coming out. So it loses something called the ligand binding domain. So the androgens, or testosterone, needs to usually bind into this ligand binding domain, and then it activates the androgen receptor. So what does the cancer do? It just lops off that ligand binding domain, and then you have this sort of truncated form. So it doesn't need the androgens anymore. It just self-activates itself. And the other area that is happening is that we know that cancer frequently mutates. And one thing that can be happening is that the ligand binding domain mutates. And you heard about this in Alex's talk, and that this happens. And so this androgen receptor now becomes promiscuous. It likes to bind to everybody and gets activated, and it doesn't need necessarily androgen, so it gets around abiraterone and enzalutamide. And in fact, one of these mutations, F877L mutation, instead of enzalutamide blocking the androgen receptor, this mutation allows enzalutamide to activate the androgen receptor. So it can actually, enzalutamide, if this mutation is there, can actually make people do worse if this mutation is there, presumably. So there are a lot where people are trying to get around this. So what does that mean in terms of treatment? And so this is one drug that's we have currently in clinical trials. And it started off as an EPI-001, and this was discovered and delineated by researchers in Vancouver, Marianne Sadar, who's a scientist, and she's been interested in trying to target the androgen receptor away from the ligand binding domain. So this is the thing that can get mutated or it can get lopped off. And so here's the ligand binding domain, and so all our treatments are focused at targeting the ligand binding domain. And she's been interested in years in trying to develop different blockers of the androgen receptor, namely on this end, the N-terminal domain. So getting away from this area where the cancer can quickly develop resistance, and try to look at this area where you don't usually see mutations, and it's necessary for that androgen receptor to work. And so she teamed up with Ray Anderson. And so Ray Anderson is another scientist, and he likes to scuba dive, and he likes to scuba dive in beautiful places. and he collects sponges and marine animals, and he chops them all up and derives chemical libraries from them. This is a sponge, and they actually found, they tested a bunch of his compounds and to see if they would interact with this N-terminal domain and could block the androgen receptor. And they found one, and it came from this kind of sponge here, and they extracted it out, and it's EPI-001 was the initial compound they found, and then it's gone through further modification, and now they have this drug, EPI-506. And so in animals, it seems to be very effective in blocking the androgen receptor and androgen receptors that are truncated or mutated. And we now have this in clinical trials in Vancouver, Seattle, and a few other places. Right now, we're still in very early stages. We're testing it in men that have progressed after abiraterone or enzalutamide. And right now, we're just trying to figure out doses and side effects and so on. So it's not widely used, or it's not been given out to a lot of men yet, but we're hoping in the next year we'll be opening up the trials to a greater number of people. Another example of how we're trying to target the androgen receptor differently comes from a series of compounds that have been developed by Art Cherkasov here at the Vancouver Prostate Center. And so what he found is he's targeting another area in the androgen receptor called the DNA binding domain. So this is a different area, again, away from that ligand binding domain where all our current therapies work at, but in a different area called the DNA binding domain. And he described a pocket. So there's a little pocket, here's the androgen receptor, and what the androgen receptor needs to do, it goes into the DNA, this is a coil of DNA, and it activates that DNA. But in order to do so, it needs to bind to it. And he found a little pocket in this DNA binding domain, and he designed a bunch of drugs that if they fit in this pocket, can prevent the androgen receptor from binding to the DNA. And again, this seemed to work in splice variants, those truncated forms of androgen receptor, as well as mutant androgen receptor. He sold he's sold off the lead compound to Roche for a lot of money. I think it was the biggest deal in UBC history or Canadian history as an example of that. And Roche is now developing this for clinical development. So that was the third concept. So the first concept was taking drugs that we have established at the late stage and moving them earlier in disease. This is the second concept where we know androgen receptor is still important even after abiraterone or enzalutamide, and trying to find new ways of targeting that androgen receptor. So the third topic I was going to talk about is precision medicine or personalized medicine. And Tom kind of alluded to it at the end of his talk, and he skipped over some slides, which I'll actually kind of talk about. So we're back to this slide. And I just want to hammer out a couple of things that Alex talked about. One is that cancer changes. So the cancer from the primary or hormone-sensitive state is different from the cancer that eventually becomes castration-resistant and metastasized. And what you're seeing here is just an example of the amount of the genome that gets altered. So on average, it's around here in the primary disease, but in castration resistance, on average, there's a lot more of the DNA that gets altered. And here's the number of mutations. So not so many in the primary, more in the metastases, just to show that the cancer is changing, it's evolving. So that's one hard part of this. Cancer learns how to change despite what we're doing. And the second concept around precision medicine to talk about is that there's heterogeneity. There's heterogeneity. What that means is that there's differences. Even within a patient, there's differences. So different tumor sites may have different mutations, but particularly between patients, there's a lot of heterogeneity. And so what this is a graphical depiction of sort of the genomic aberrations that are happening in a group of men. So each column is an individual man, and the rows are the genetic abnormalities that were found in these metastatic biopsies. And if you see a colored box, that means there is an abnormality in there. So for these few genes up here, one of them being androgen receptor, so at the top, where's my arrow? There it is. So at the top, in these few genes, there's a lot of men had problems. And for example, androgen receptor, a lot of the men within their cancers, there was an abnormality in androgen receptor, so that's what we would expect. But once you start going down here to the other genes, you can see a lot of white, meaning that there's a lot of men didn't have abnormalities in the genes, but some did. And so this is a better way of depicting it. And here's a column graph. So most of the genes, most of the time, it's less than 10% do we find something. So meaning that we need to know what's going on within that cancer, within that individual's cancer, because it may not be in all patients. So here's an example that came up that was important, and that's DNA repair genes. So if there's a problem in the DNA repair genes, we can see that in 20% of men. What that also means is that 80% of the men did not have a problem with DNA repair. So if we used a drug that targets DNA repair, it may not work as well in 80% of the men. And if we took that into a trial, that means we might declare a drug not really active because most patients aren't responding. But if we took that drug and we tested it only in those 20% of men, then we would say, oh, this drug is active. So it's about finding who those men are. So why is DNA repair important? Why are we actually quite excited about it? And actually, Tom had a bunch of slides on this that he skipped over. And that's because we know we can target these cancers that have these DNA repair problems. And this goes back to the BRCA2 that Dr. Schrader was talking about, and also Alex talked about. And there's a series of drugs called PARP inhibitors. And what these do, they are synthetically lethal to tumor cells. So what does that mean? That means, so if you have a normal cell that is proficient, so meaning a cell that has normal DNA repair genes, and you hit them with this PARP inhibitor, nothing happens. They're okay. A little bit happens, but more or less they're okay. But if you have a cell that has these genes knocked out, and you give them that PARP inhibitor, it actually results in cell death. So it's more selective. And there was a trial that was done by the group in London, led by Johan de Bono. And what he did is he did a phase 2 study of olaparib, but he molecularly classified all the patients. Everybody that went onto the study got a biopsy, and they looked at that cancer, and they looked at that genome of the cancer. And all the people that responded to olaparib had some sort of DNA repair abnormality. So that's what these colored boxes are showing. And then if you looked at the patients that didn't have a response to olaparib, most of them did not have a DNA repair abnormality. So it goes back to, if you had done a study and you just took patients with no DNA repair abnormalities, you would say this drug is not active. But if you just did the study in patients with a DNA repair abnormality, then you would say this drug is very, very active. So it's all about defining who those patients are. So, and then Alex talked about liquid biopsies, because, biopsying the bone is not fun for anybody, and it can be difficult and challenging for our patients. And so there's a lot of efforts across the world to develop liquid biopsies. And what this is just sampling the blood. And we can look at it, we can actually find circulating tumor cells in the blood, and Alex had showed earlier, we can find the naked DNA flowing around the blood. And so we can pick these things out, and then we can actually analyze them, which tells us about the cancer. So instead of having to take a biopsy, we can just sample the blood, which is easier, you can do it multiple times, and certainly less painful. So this is an example of some of the work we've done. Again, an individual patient is in the rows, and the colored boxes mean that there's a DNA abnormality or a genomic abnormality. And these arrows tell us about how long patients were on for enzalutamide. And so just looking at the figure in a totality, a lot more colored boxes are on this side of the slide, a lot less colored boxes are on that side of the slide. And so if you had a genomic abnormality, you had a shorter time on enzalutamide. So that there's a relation. A genomic abnormality is related to a short time on treatment with enzalutamide, while the patients that didn't have these genomic abnormalities had a longer time on treatment for enzalutamide. So that's a little bit of a predictive factor that we could use to say, not quite yet use, but predictive factor that may tell us about who would be best treated with enzalutamide. And so we've expanded this work. We can now look at a lot more genes. And here's that BRCA2 gene here. So we can pick out patients instead of having to biopsy them like they did on that trial that was done in London where they biopsied every single patient. Here we can use a liquid biopsy and then identify these patients that might be best suited for these PARP inhibitors. And we may be able to pick patients out for other treatments. So this is a trial that we're just about to start. in Canada, and it's looking at an inhibitor, a CDK4/6 inhibitor, something called palbociclib. This is already approved for breast cancer. But what we know in prostate cancer is that, or at least we know in cancer, is that if a cancer cell has something called a cyclin D1 gain and a wild type RB1, they may be more responsive to a CDK4/6 inhibitor. And so but this in prostate cancer, in patients with prostate cancer, this only occurs in 5% of men. So what we want to do is be able to pick out this 5% of men and then give them this drug to see if it works. And so that's what we're doing. We're going to screen anybody that's progressing after abiraterone and enzalutamide, and we can just screen them with a blood test. We don't need a biopsy. And if we see this genome signature present, then they will go into the study and we'll see whether this drug is effective for them. But this is kind of inefficient. That means I have to screen hundreds of patients to find these small numbers that will fit this, because it's only 5% of men. So what we're doing is, next step that we're doing now, and this will start up in about 2017, is something what we call an umbrella trial. So across Canada, we're going to screen about 500 men, and then they'll, over the next couple of years, and then we'll be able to look at the genomic abnormalities within those 500 men, and depending on what genomic abnormality they have, we will slot them into the appropriate drug. Or a drug that we think will work for that genomic abnormality. So this is what I mean by precision medicine. We want to take that individual man, look at what his cancer is, what the genetic makeup of that cancer is, and try to give them the most appropriate treatment that we can think of. The best example, as I mentioned, seems to be this BRCA2 with a PARP inhibitor, but we need to expand on this and find other treatments for the 80% of men that don't have this BRCA2, for example. I'm going to end by just showing a couple of examples with this precision medicine and how we can bring the lab, what Alex talked about, into the clinic. This is a gentleman who presented on this timeline. Initially, he presented, his PSA was only 9 when he was diagnosed, and he actually had metastatic disease at the time with multiple bone metastases. And so we went ahead and we gave him typical hormone therapy, degarelix, bicalutamide, and he also received docetaxel chemotherapy, like I talked about at the beginning. And he initially did well, but then within that year, so he already started progressing. He already started developing castration-resistant disease, and his PSA started to go up, even within a couple of months of just finishing his docetaxel. He actually developed skin metastases, and this is something that I've rarely seen in men, where the cancer was actually in the skin. He also was developing new bony metastases. Well, at this time point, he actually had a cell-free DNA sample done. And in fact, he had one of these mutations that turns the androgen receptor into a more promiscuous receptor. And it actually turns it so that bicalutamide, Casodex, which normally blocks the androgen receptor, it actually turns it into an agonist. It actually activates the androgen receptor. And so this gentleman, he stopped his bicalutamide, obviously, and he went on to receive abiraterone and enzalutamide combination in sort of an experimental protocol, and he's had an excellent response afterwards. This is another example. This patient presented with a very aggressive prostate cancer. In fact, he had liver metastases. And so he received chemotherapy, and it's a cisplatin, something called a cisplatin type chemotherapy. He received 18 weeks of it, and then we had to stop because this cisplatin chemotherapy is pretty toxic. People get pretty beat up after 18 weeks. He had an excellent response, though. These little black dots, so this is his liver, and these black dots are the cancer within the liver, and they completely disappeared after his chemotherapy. Unfortunately, this is a very aggressive cancer, but I'll get to that in a second. We did do a biopsy of his cancer, and we also looked at both the biopsy, the genome, as well as the genomic abnormalities in his cell-free DNA in the plasma. And as you can see, number one, that the biopsy and the plasma, this is looking at the individual chromosomes, and then if it's down here, that means there's a loss, and if it's up here, there's a gain in the genome. But just looking at these colored dots, it looks very similar. So the biopsy is very similar to the plasma. So we really didn't need to do that biopsy. We could have just used the plasma, but we were still experimenting with this. But one thing to note is that he did have a loss of this BRCA2 gene, which we've been talking about over several of these talks. So we knew that. Unfortunately, within 3 months after stopping his initial chemotherapy, his cancer started progressing again. You can see, again, this is his liver, and you can see the 3 big black spots of cancer. it actually went into his brain as well. He received radiation therapy to his brain, and then because we knew he had this BRCA2, this genome abnormality, we gave him olaparib, which was one of these PARP inhibitors. He had no toxicity, no side effects to this drug whatsoever. It's a pill that he takes every day, no side effects, and within 2 months, his cancer is already shrinking, and within the brain, it's completely disappeared after his radiation. Radiation probably works very well in BRCA2 as well, and so he's had a very good outcome with this. And I wouldn't have given this unless I had known he was BRCA2, unless I had known that he had the BRCA2 abnormality. So I just covered 3 concepts, and I hope you've taken something away from it. Number 1, we're trying to bring our late-stage therapies earlier in the disease to have greater benefits. Number 2, we're still interested in targeting the androgen receptor, and there's a couple of new drugs, or actually several new drugs that are coming down the pipeline, which we hope will work after abiraterone and enzalutamide. And then thirdly, how we're trying to understand the cancer at more of a genomics level and in individual patients so we can target that therapy much better. Thank you very much.
Fantastic. Thank you, Kim. So we're now going to take a question and answers. Again, we'll be pass your cards out to the aisles, and our volunteers will collect them. I have a few questions from Seattle. Are we live in Seattle and Portland? Hopefully everybody can hear us. Okay.
Yes.
For Alex and perhaps for Kim, question, will liquid biopsy information make a difference before CRPC develops, and will it be useful to detect cancer? In other words, all of this genomic study that we're doing, how applicable is it in the very early stages of disease, or even before knowing that there's disease?
That's a great question. I think, as you saw from Kim, the kind of paradigm that we use is learning from the later stage where really disease is easier to study because the tumor burden is higher, and then kind of moving those concepts earlier as soon as we can. So in men with a lot of metastases, there is a lot of cell-free tumor DNA in the blood, so it's easier to study. In men with less of a disease burden, there will be less tumor DNA. So what we need to do to be able to move this earlier is develop more sensitive techniques, and that is happening. So definitely in some other cancers like lung and colorectal, cell-free DNA is really being touted as a diagnostic tool. So I think it will head that way in prostate too. It's a case of improving our techniques, becoming more sensitive.
Okay, and Kim, perhaps you can answer this one. Is the liquid biopsy test commercially available either in Canada or the U.S., Seattle, Portland, or is it still under investigation?
It's still under investigation because we don't know what the clinical utility of this yet in prostate cancer. So actually in lung cancer, it's actually a standard test, approved test to detect certain mutations in lung cancer because certain mutations may predispose lung cancer to a sensitivity to a particular drug. So that's already an out there test that you can purchase. But cell-free DNA and prostate cancer, no, it's not available outside of a research.
Okay, question from Seattle for Tom. Does removal of the testicles lower testosterone? Yeah. Okay, should that be done if the injections fail? In other words, what's the role of surgical castration? There actually was another question in one of the cards.
Sure.
Why aren't we using surgical castration today?
Well, that's a great question. So first of all, yes, removal of the testicles does lower testosterone in a man who's not on hormonal therapy. It's thought to be roughly equivalent to the results of the pharmacologic therapies like leuprolide and degarelix in terms of its testosterone reduction. So we typically don't use it if a patient is already on a pharmacologic therapy that's successful. There are occasionally patients who, for reasons that we don't always understand, don't fully respond to the injectable drugs, and orchiectomy may be helpful in those patients. But zooming out and speaking a little bit more broadly, why do we not use it more often? we probably should use it more often. But there are a couple of features of orchiectomy that have led to it kind of taking a back seat to pharmacotherapy. One is just patient preference for an injection versus having a surgical procedure that removes the testicles. The other is that orchiectomy is irreversible, and to the extent that sometimes we choose to use hormonal therapy on an intermittent basis, that's only possible with drugs.
Okay, have you got any questions from Portland, Tom?
Oh yeah, we have lots and lots of questions here. It's a very curious audience. So Larry, we'll start with you. This kind of takes us back to the earlier session, but we'll kind of mix it in. Folks are curious about focal therapy, specifically focal cryoablation and HIFU, and the Canadian experience with those.
So focal therapy is the treatment just of one part of the prostate, if you will, and it ranges from trying to identify the cancer using an MRI imaging study to see where the cancer is. Like the analogy would be to breast cancer, where the treatment used to be routinely a mastectomy, removing the whole breast, but then it moved into the era of lumpectomy, where just the lump is removed with some radiation therapy to follow. And people are trying to see whether or not that concept would work in prostate cancer. There are some challenges with that. The biggest challenge is that prostate cancer tends to be multifocal. In other words, it pops up in all different parts of the prostate, and it's not always just a single sentinel lesion or one tumor that you can target. Whether it's HIFU or cryotherapy or brachytherapy or other forms of energy or drugs injected into the prostate is irrelevant. Anything that will kill the cancer can be used. The question is it the right way to go? Can we just treat one part of the prostate and cure the man? My own personal feeling is that there will be some cases where there is a single focus and you probably can cure. However, in most cases, it's just active surveillance plus, if you will. In other words, you're treating the big lesion that you can see, and you have to continue to watch the rest of the prostate, because undoubtedly another cancer is going to grow there, and you're going to have to treat it at a later date. So it maybe moves the timing up, the timeline of the biology of the cancer just moves it up a year or 2 years or whatever. It's all under investigation. I know that in the States, there are centers that are doing that. If you go down to Palm Springs, you'll see the advertisements down there. There are guys doing it, advertising to do it. I think it's still experimental. It should only be done in an investigational world, and until we know the answer, and it will take a long time. You asked if it was available in Canada. HIFU is available in Toronto. Has been for a number of years. It's not available on the West Coast that I'm aware of. And it might be available in Montreal. I'm not sure. But cryo is available in London, Ontario. I'm not sure why a Portland question wants to know about Canada, but there you go.
Well, you guys are pretty close, so some folks like to travel. Can I just kick in one more question here and then turn it over to you, Larry?
Okay, go ahead.
So I've got a couple of questions I'm going to combine about how we use Provenge before or after chemotherapy and why, and just a general question about immunotherapies in prostate cancer. So with regard to Provenge specifically, in general, in hormone-resistant prostate cancer, we tend to use it early. So that up until recently meant before chemotherapy. Now that we're using chemotherapy in hormone-sensitive disease, as Kim alluded to, paradoxically it might be after chemotherapy, but in terms of hormone-resistant disease, we tend to, if we're going to use it, we tend to use it early. We don't tend to use it at the same time. It's not been studied that way. The concern would be that the chemotherapy might suppress the immune response, but we don't honestly know whether that's the case or not. In terms of immunotherapies in general in prostate cancer, Provenge is the only approved one. We've had 2 phase 3 trials of ipilimumab, which is an immune checkpoint inhibitor that unfortunately did not yield positive results That was the next greatest hope for more immunotherapy. Julie Graf is working with pembrolizumab, a PD-1 inhibitor that's yielding encouraging results in a subset of patients in an early stage study. I think for that to be successful, we're going to need biomarkers like Kim alluded to, where we identify the right patients, and we're just beginning to do the work to sort that out.
Okay. I have a question here for Alex. How frequent are the blood samples taken, and what are the changes you're looking for? I guess that's probably was answered by Kim's talk as well afterwards. And then there was another one here that you might want to address, or Kim could address. What about stem cell therapy in prostate cancer?
I'll leave that one to Kim. But so how frequent are the blood samples taken? So that varies by the study that we do. So we try to segregate the men that we look at, the patients that we look at, into what therapies they're receiving. And so in some situations, we might only be interested in two samples, one when they just start their therapy and one when they end it. So to see maybe if there's any differences between those. It really depends on the study, so we kind of tailor it. And at the end of the day, we're grateful if we can receive even a single sample. In terms of changes that we're looking for, it's really those sort of clinically actionable alterations that Kim hinted at, all the changes that might be relevant for the umbrella trial, for example. It's the changes that have been shown to be the most common in prostate cancer. And as we move forward, we hope to expand to look at more and more genes. So at the moment, we look at about 50 to 100 genes.
Great, thank you. We have another question from Seattle. This is for Dr. Chi and for Dr. Beer. How do the newer drugs for CRPC affect quality of life?
This is Tom. Maybe I'll jump in and talk about the hormonal drugs and then turn it over to Kim about the experimental drugs he talked about. So in the randomized studies that have compared either placebo or some other standard to the newer drugs, on the whole, quality of life is better with the drugs than without. So they affected favorably. Now, that doesn't mean that they don't have any side effects at all. It just means that on a net basis, when you trade the side effects of the drug against the adverse consequences of a cancer that's not as well controlled, you come out ahead. The hormonal drugs do tend to cause more fatigue and have some other specific side effects for abiraterone that might be fluid retention and liver abnormalities. For enzalutamide, it's more fatigue than abiraterone. So there are in individual patients adverse quality of life effects, but on the whole, when measured against the alternative, quality of life's actually improved on therapy versus on placebo. Now, in terms of the new drugs that Kim talked about, there's so many, I don't know if he'll get a chance to talk about all of them, but maybe at least, Kim, could you comment on the PARP inhibitors, because I think those are most commonly used.
Yeah, and as Tom said, it's all about weighing off the risks versus the benefits. And for some patients, getting a drug, even chemotherapy, can be very well tolerated. And for that individual patient, there wasn't a lot of side effects. So I've had a man, he ran the Vancouver Marathon while he was receiving docetaxel chemotherapy. His times were a little slower than the year before, but he still did okay. So for the individual, it's something that you have to weigh out for the risks versus benefits. And as a treater, if we are seeing too many side effects, we try to reduce the dose, number one, and we actually stop, right? This is, we don't want to terribly adverse, or we don't want to affect a person's quality of life. So at an individual level, we reduce the dose or we stop the drugs. Specifically to the PARP inhibitors, they are actually well tolerated generally, although they do have side effects. And I think in that paper with the PARP inhibitor, 30 or 40% of the men ended up getting a dose reduction. But it is a pill, so if you end up getting side effects, you just reduce the dose, or stop it, let a recovery, and then restart it again. Other treatments are going to be more toxic. For example, some of the immunotherapies, the new immunotherapies, there can be pretty dramatic side effects in a small proportion of patients. So for those individuals, not such a great thing, but for the other patients that don't get the side effects, that respond better. So that, again, goes back to the precision medicine. If we can find and delineate who are the patients that are most likely to respond to the drug, then we've shifted that risk-benefit ratio, right? If you only have a 20% chance of response, but a 50% chance of side effects, then that's not a great risk-benefit ratio. But if you have a 100% chance of response and a 50% chance of side effects, well, that's a good risk-benefit ratio, for example.
Want to comment on the stem cell question?
So that's referring to the idea that there are rare cancer cells within a tumor that are kind of the mothers of all the other cancer cells within a tumor, and that these mother cells are more resistant to treatments, and they don't respond as well to treatments. And as far as I'm aware, there's no treatment that is specific for stem cells at this time in prostate cancer. I don't know if Tom might, I don't know if you know any more than that.
Yeah, we have some secret stem cell treatments here. No, I totally agree. We don't have that, but the world is very dynamic, so we'll see if something like that emerges.
Certainly hoping that we can get our audio to Seattle fixed so that Tia can weigh in a little bit this afternoon. We have just a couple more minutes before lunch. I think this is an important question. Please comment on the recent study in New England Journal that showed indifference or no difference in 10-year survival between active surveillance, surgery, and radiation. I think it's a very important question, and the media picked up on it. It didn't, in my view, and perhaps Jennifer can come up and address it as well. In my view as a surgeon, it wasn't a surprise. In Canada, we have been using active surveillance in a lot of men for many years with low-risk disease. 76% of the men in this trial, this was a big study done in the UK, and congratulations to them for getting it done. It's very difficult to randomize men, to say to a man, we have nothing, we're going to do nothing, we're going to operate or we're going to radiate, and a computer is going to decide for you. So doing those kinds of studies are pretty challenging. And they completed the study, and they showed that at 10 years there really was no difference in outcomes with respect to survival, with biochemical recurrence. And it really isn't unexpected because 76% of the men actually had low-risk disease or PSAs less than 10. So we don't really expect to see differences. I'm hoping that they continue to follow because we might see differences later on. The differences are in the side effects of the treatments. And all three have side effects. Even active surveillance, where you're not doing anything, has a side effect, but it's a psychological anxiety type of a side effect. And in that group of patients in the study, they had the highest risk of developing biochemical progression and even metastatic disease, but the absolute numbers were low. Jennifer, do you want to talk through a radiation lens?
This would come up. So this is the PROTECT study. So I do think if anyone ever wants to look at quality of life, I do think it's one of the only large studies that is going to give you a randomized idea of what people go through after radical prostatectomy, even though it's not robotic.
It wasn't mine.
It wasn't yours, but it wasn't my radiation either. And they also use 3D conformal. So all these new IGRT and things like that I think might change things. But in terms of what Dr. Goldenberg is saying, I agree it's a low-risk population. It's often who we survey, but what is interesting, even in the low-risk population, there was still an increase in progression and metastasis in those patients that were on surveillance. So I think it does remind us that even patients on active surveillance, we have to be careful because they may not die of their disease any differently than someone treated up front, but it does remind us that they could progress all the same. The other thing I would say just with the active surveillance group, 20% of them did get a radical prostatectomy and 10 or 13% did get radiation. So, even their quality of life was still impacted by the treatments. In terms of radiation and how it affected quality of life, interesting to look at the rates of incontinence, I think, in radical prostatectomy and how urination was not a major effect in people getting at least 74 gray in that population, but definitely a detriment to the bowel side effects. So I think it's a good one looking at the quality of life paper for us to give patients just to get a general sense. Not that they're easy to read, but for those that are really seeking out good information, I do think it's good.
I think it supports what many of us who are rational in our approaches would agree on, and that is apples and oranges. They're both good from a cancer control point of view, but choose your poison. They have different risks, whether it's bowel or urine or sexual function. You have to do your due diligence in deciding what you want done. And if you do choose or are recommended to do active surveillance, Jennifer said, that means active surveillance. Doesn't mean we're going to send you away and see you in 10 years. You're going to come back and you're going to have repeated studies, but whether they're MRIs or PSAs, rectal examinations, biopsies, and so on. It's a very active process, so keep that in mind. Just before lunch, I'm just going to read one comment. Why not give patient a digital copy of Dr. Goldenberg's talk? Blah, blah, blah. Or something similar to better describe the operation to patients. I found it very helpful to better visualize considerations for healing. It could have been anybody's talk. I think the point is education is important. And we've learned that in the last 15 years. And certainly all of the supportive care programs here, Seattle, Portland, all of you, I hope, are exposed to adequate education and information, because information is powerful and it helps you be comfortable with whatever happens to you, no matter what type of treatment you choose. I'd like to thank our speakers from this last session very much, and it's lunchtime, so each center has its own plans for lunch. We're all going to West on Granville. And Kim is paying.